Welcome, everyone. Thank you so much for joining us for today's discussion on making decisions while living under the threat of COVID-19. My name is Lillian Maron, and I'm the Director of Outreach and Education at End of Life Choices New York. We're excited to offer this webinar with our co-host, Death with Dignity Albany. So first, I'd like to tell you a little bit about my organization, End of Life Choices New York. We're a nonprofit organization that seeks to improve end-of-life care and expand end-of-life options to ensure a peaceful death for all New Yorkers. And we do this in a variety of ways. We educate the public and healthcare professionals on end-of-life issues. We provide free counseling and support, this is what Judy does, to people who are preparing advanced directives, caring for a terminally ill loved one, or who are approaching the end of life themselves. And we pursue legal and legislative reform, including implementation and enforcement of advanced directives and legalization of medical aid in dying. We're joined by Bonnie, Director of Death with Dignity Albany. Bonnie, please tell us about your organization.
Thank you, Lillian, and good afternoon, everyone. I join Lillian in welcoming you. Delighted that we have a full house of 100 people joining us today. And we're very pleased today to join forces with End of Life Choices New York to bring you this joint co-sponsored program with our speaker, Judith Schwarz. Death with Dignity Albany has a dual mission. We provide a forum for discussion and for learning about a wide variety of end-of-life issues. And we also advocate for the passage of medical aid in dying legislation in New York. We're an independent, nonprofit, grassroots, volunteer-run organization. And our organization was founded in 2015. We are also members of the New York Alliance for Medical Aid in Dying, which includes End of Life Choices New York, Compassion and Choices New York, and Death with Dignity National Center. And it was formed to enable us all to speak with one voice to promote medical aid in dying. So that's a little bit about us. And now I turn it back to Lillian, who will introduce our speaker.
Thank you, Bonnie. So before turning it over, I just want to go over some logistics. So this is a webinar style, which means that we will not be able to see or hear you, but there will still be an opportunity for you to ask questions, and we hope that you will. So we're going to save time. We're going to have a lot of time after Judy's talk to answer those questions. So without further ado, I will introduce our speaker, Dr. Judith Schwarz. Dr. Schwarz is the clinical director of End of Life Choices New York and was the East Coast clinical director for Compassion and Choices. She earned a doctorate in nursing research from New York University and has been a nurse for almost 50 years. She publishes regularly in nursing and palliative care journals with colleagues in other disciplines. She developed the End of Life Choices New York Dementia Directive, which is designed to clearly and easily allow an individual to document their wishes, including wishes regarding hand feeding for the different stages of dementia progression. She has counseled hundreds of patients suffering from incurable and progressive or terminal illnesses and their families about end-of-life options. So Judy, I turn it over to you.
Hello, everybody. I have to tell you, I miss seeing your faces. I wish we were all together, and I'll look forward to when we're able to be together. This is going to be an interesting webinar in that I've never really addressed some of these issues before, but let me tell you what I hope to discuss in the following time we have together. First of all, what we're going to talk about is what we've learned about this virus over the past 6 to 8 months. And then we're going to talk a little bit about coronavirus fears. Are these fears realistic or are they less so? And then practical steps you can take to cope with those fears. Particularly important now is the issue of making and communicating choices around medical interventions in completing advanced directives. Now, we've talked about this before, but it has particular significance now, and we'll talk about why that is so. And then, as Lillian and Bonnie said, we're going to have lots of time for questions and answers. So let's move on to the next slide, please. So, in thinking about this, I went back and looked at the messages I was sending out over time to our members via constant contact. Starting in March, I began to send out sort of regular little notes to our members. And then 6 months ago, which was when I started doing this in March, we were all quarantined, sheltering in place, and living with many, many frightening unknowns. But slowly over those months, we've begun to learn how to stay safe, right? And by the end of April, we knew more. Here in New York, we came together each night about 7 o'clock in support of hospital staff, and we all clapped and waved things out of the window and saw each other across canyons in New York City, sort of supporting each other as we were supporting hospital staff and other essential workers. I wonder whether you guys in upstate did something like that in cities or in small towns. It was really kind of a wonderful experience. And then by the end of April, we began to cautiously make plans to meet on park benches, but of course, appropriately socially distanced and masked. But dying alone in hospitals or long-term care institutions was and still is a very significant problem for many patients and for their loved ones. Next slide, please. So where are we now regarding COVID in New York State? Certainly it's true that our knowledge about the COVID virus is evolving, and there are lots of really smart people around the world actually learning about it and sharing that information. As it happens in New York State, our rate of infection, which was horrendously high, I don't have to tell you, we were the hot center of COVID in the country for some awful months. But our rate of infection in New York State and for hospitalizations and deaths has significantly declined over the past several months. The rate of testing has slowly increased. However, contact tracing is still low. Efforts have been made, but so far they've been really not very effective. When I was sort of preparing for this, I want you all to know that there's very good general COVID information at the following website at www.coronavirus, all one word, health, coronavirus.health.ny.gov. I'll say that again, coronavirus.health.ny.gov. There's a lot of really good, helpful, sensible, and non-scary information to be found on that website. In addition, there's guidance for those who are at heightened risk of infection, and that can be found in Cuomo's Matilda's Law. You do know his mother's name is Matilda, and she is indeed an elderly person. But we'll talk more about that later. Next slide, please. So, reasonable versus paralyzing fear. I did some research and reading, and I got to tell you, there's really some very interesting research on the psychology of COVID fear. For those of you who are feeling particularly fearful, you're not alone. Lots of other people are as well. And there are some interesting studies that show the following thing. Maybe you all know this, but we tend to fear unlikely catastrophes like a terrorist attack much more than we fear common events like the seasonal flu. And as our emotions rise, heightened emotion impairs a realistic perception or assessment of risk. Now, there's no doubt that there's a great deal of uncertainty and unpredictability about the COVID virus. We really don't know yet exactly why it strikes, who it strikes, and why some people have very, very significant long-term effects and other people have no symptoms at all. So there's a lot we don't know for sure. And that sense of uncertainty and unpredictability can lead to an increased sense of lack of control, which in turn causes a heightened fear. So the goal here is to take back some of that control, to acquire a sensible information about what to do will help diminish the risk and helps lessen our sense of vulnerability and fear. So we want to have good, accurate information that will help diminish the sense of risk and help lessen our sense of vulnerability and fear. All right, let's move on to the next slide, please. So how to stay safe, and I put in brackets, sane, if that's not too presumptuous. There is absolutely no question that we should all maintain social distances of 6 feet at least when outside of our private domiciles. And for sure, mask up when we're away from family members, from close family members, or our personal pod. And we'll talk about that in the next slide. Plus, of course, when you're outside and you come back home, you must wash your hands. Going to a grocery store, handling things that are not in your home, you got to wash your hands. You got to cover your coughs and sneezes. Somebody told me recently that they saw somebody with a mask who, in anticipation of a sneeze, pulled down their mask and then put it back up, I guess, after they sneezed, which really is not what we want people doing. Clearly, you need to avoid crowds and stay home if you're feeling sick. And you don't even know what it might be that you're feeling sick with, but you should stay home in any case. Be sensible, be respectful of other people. So you should stay home if you're feeling sick or you know you've been exposed to somebody who is positive. Now, let's talk about those vulnerable folks. Vulnerable folks include those who are 70 years of age and older, those who have an immune compromised system, those with an underlying chronic health issue like COPD, chronic obstructive pulmonary disease, diabetes, hypertension, increased blood pressure, or obesity. We know for a fact that those people are more vulnerable. And if you are in any of these categories, you should follow the additional steps in Matilda's law. It's not really a law, it's just guidance. For example, avoid public transportation if you possibly can. Pre-screen all visitors. So that's ask them whether they've been around other people who are positive, take their temperature. Be sure that you're not letting anybody in that could infect you, and be damn sure that they're wearing a mask. Don't visit where there are multiple people. Don't go to any kind of party's backyard or on the streets, and practice constant masking. All right, next slide. So a note about pods. Pods or bubbles are groups of people with whom we regularly socialize. Usually we're not socially distancing when we're with our pod, but you certainly must follow all guidelines when you're apart from members of your pod. It's a safe practice if all individuals, including kids, follow all the guidelines when they're apart from their pod. For example, as you know, social distancing, hand washing, wearing a mask, when around anyone outside of the pod. So this takes a little practice. I know that parents or grandparents with young kids, young grandkids, are sort of expanding their pod carefully. And you can do it, but you have to be sure that you're still following guidelines when you're not with members of that pod. And this is certainly not appropriate for members of vulnerable populations. Next slide, please. So let's talk about fears. Fears about going to the hospital. After 6 months of living with this bloody thing, this epidemic, this COVID, many are appropriately still fearful of having to go to the hospital for any reason at all. As a result, treatable illnesses are not receiving appropriate care. For example, people with ongoing cancer care, chemotherapy, radiation are not going to the hospital to get it. They're not getting treatment. There's no treatment provided for either treatment or prevention of things like heart attacks and strokes. So people are dying unnecessarily in ways that they could previously have been treated and the death prevented. I think that perhaps many of you are beginning to use telemedicine, where you check in with your healthcare providers over the phone or over the internet. And that's certainly a useful substitute for some things. And we're having to get creative in ways that we never were before. And it does require some technical skills that not everybody is comfortable with. So telemedicine is filling the gap, but it certainly does not take the place of a physician that you've known for a long time, sitting across the desk and doing a physical exam. So we are missing some of that prevention and treatment, and as a result, people are dying. Hospitals and nursing homes continue to restrict visitors to prevent, of course, the future further spread of this disease. I think there's beginning to be some loosening of that in some nursing homes. I sure hope there is, because this is such a terrible thing. You can die of loneliness. And I think some of these elderly people who are in nursing homes and haven't seen their loved ones for such a long time, it's such a tragedy. This fear of hospitalization results in a terrible choice for people, either to stay at home without treatment or go to the hospital and be isolated from loved ones. It's particularly awful when you're unable to advocate for yourself effectively or communicate your wishes to people that may not be able to understand what you're saying, or you may be not able to be clear about what your wishes are. People for sure fear being apart from loved ones when they're sick or possibly dying. And some are therefore making a choice to stay at home under hospice care with close family members in attendance. I think that people are signing up for hospice a lot sooner than they ever did in the past, which is a good thing. But at the same time, they may be avoiding treatment that could have given them a decent quality of life for longer. It's a terrible choice. It's a terrible choice that people are having to feel like they have to make right now. Next slide, please. So we do know, in addition to learning a lot about medications and treatments that are becoming, we know, successful for treating the COVID virus, which is not hydroxychloroquine. Do I need to tell you that? I'm sure you know that, right? As opposed to some people who apparently don't. So we know about that. We know about treatments, and physicians are sharing what works with their colleagues around the country, and that's a good thing. We also know when it is crucial to go to the hospital. And the following are some of the symptoms that require hospitalization. So the first is acute trouble breathing. So this is a difference. We're not talking about people who've had a chronic difficulty breathing and maybe they have oxygen in the house, but they've lived that way for a long time and they're kind of stable and it's chronic shortness of breath, and it's not a big deal. This is a new thing. All of a sudden they have acute difficulty breathing, or they're experiencing chest pain and or pressure in the chest, or they're having difficulty staying awake, or they're experiencing new confusion. Again, this is not somebody who's been confused for time and their family knows it and they know, no, this is new, this is different. Or blue lips or face, cyanosis. These last several symptoms mean that the oxygen level in the blood is dropping dangerously. So these are all reasons to get yourself to the hospital quickly. I want you to know that hospitals have learned a great deal about how to keep people safe when they come to the hospital, either for treatment for things that are not COVID related. There's a separate area for people that come in with potential COVID symptoms, and they are kept apart from those who have another thing like a heart attack or potential stroke, they're kept separate. So you should let that be comforting news. And many people that come to the hospital don't have to stay there for great long periods of time anymore because they're much better at treating these symptoms. So I want you to be encouraged to talk to your physicians, tell them what your symptoms are, follow their advice. And if they tell you to get to the hospital, follow that advice and do that. And particularly if you have any of the symptoms that I've just mentioned. The other thing I would say is please avoid taxis or other people's cars for transportation to the hospital if you possibly can. An ambulance is much safer for you and for other people who might enter those cars. So, next slide, please. This is where I should start doing some tap dancing and telling jokes. This is kind of getting scary stuff, isn't it? So, what can we make good come out of all of this togetherness, right? Preparing ahead of time for a crisis. So let's make something good come out of it. And this is the time to create or update your medical directives. I talk to people all the time who, when I ask them if they have a healthcare directive, they say, oh yeah, I did that 20 years ago. Don't worry, it's all taken care of. No, take that document out. Sit down, talk to your family members and your appointed healthcare agent. I know you've heard me say this before. A person is a much more effective spokesperson for your wishes than a piece of paper. For sure, a piece of paper is better than nothing. But I want everybody that possibly can to appoint a person and have a very specific conversation with them and the significant others in your life, and talk to them about what's important to you, what you're most fearful about, and what you want for yourself if, in fact, you end up being COVID positive. You need to talk in particular about the life-prolonging interventions you want or you don't want. Particularly, think about the use of mechanical ventilation. Now, I think that they're not automatically putting people on ventilators the way they were, several months ago when they didn't know what else to do. They've learned a great deal about other less intrusive ways of treating people and keeping them oxygenated without having to put ventilators or tubes down people's throats to connect them to a ventilator. On the other hand, let's also keep in mind that what most people are fearful about is being dependent upon aggressive mechanical interventions like ventilators for an indefinite period of time. They're worried about chronic dependency. And that's not something that should be clouding your fear right now. You can also suggest, and you should write this stuff down, you can request a trial of aggressive treatment. You can do that with any kind of intervention. And you can designate a time ahead of time with your healthcare agent and your family members when, if at the end of that trial period, you have not been successfully treated with this aggressive intervention like the mechanical ventilation, then you can be treated. You switch the goals of care from aggressive life prolonging to aggressive comfort care. And that can be done. Anything that's started can be stopped when it's no longer providing you with what you hope to get from it. Now, these are tough conversations to have. I understand that. But this is the time to have those conversations because there is a pressing need that we haven't seen previously in this country. So I want you all to really think long and hard about this and get everybody together. You can do a lot of this by phone, You can get your kids on the phone, do a conference call. You don't have to do Zoom calls, although those are good. FaceTime is good as well. And also know that even if you're in the hospital, those ICU nurses and the ER staff are much more adept at keeping family members connected to their patient in the hospital by using technology, by using smartphones, by having iPads that they connect with the family at home and the patient there so that there is a more completed loop of communication. It's not the same as having somebody there holding your hand but it's better than being completely on your own. All right, next slide, please. So if you have to go to the hospital, what do you need to bring with you? I think calling it a hospital kit is a really good idea. You want a sheet of paper with clearly printed information with the name and the contact information for your healthcare agent and for significant others. And if you can give the healthcare team that's going to be looking at this the best time to contact this person and maybe a secondary number if the first one doesn't work. I can't tell you how many times people will leave me a number to call and I call them back and I get a recorded message, and I call again and I get a recorded message, and it's like, hello, what would be a good time to speak to you directly rather than your phone is what I wonder. So the more information you can put clearly and legibly into that piece of paper that says, here's the name and the contact information for my healthcare agent. So that would be a phone number, an email address, a secondary phone number, and the best time to get a hold of that person. And also for significant others. You know, you might have a healthcare agent, but you also have an adult daughter or an adult son you've been living with who also know what your wishes are. It's good to have some follow-up, some backup people as well. Plus, you need a list of your current medications and your primary care physician's contact information. Don't assume that they'll know who that is or how to get a hold of that person. You should have a copy of your completed advance directives and your written decisions. Write down your decisions about resuscitation and whether you have strong feelings about feeding tubes. Again, anything that's started can be stopped if it's no longer effective or working for you. Also bring an iPhone, a charger, and or an iPad if you have one to be able to contact family members when you get there. So let's go to our almost last slide. In summary, learn how to stay safe. Follow sensible guidelines about masking, social distancing, hand washing, and avoiding crowds. Try not to listen to the craziness out there because there is a lot, and there's a lot of unfounded, unhelpful stories that are not based on any kind of scientific research, and that's what we need here is well documented, reliable, reputable sources of information. Do stay in touch with your loved ones and your friends, either by phone or by text or by FaceTime or Zoom. And you can keep writing letters. It's a good thing to do, and it documents how you're feeling at the time, which can be really wonderful to look back on. The goal here is to try to relieve social isolation. We end up, in our own little shells, and the less we do and the fewer people we speak to, the fewer we feel like we can or we should. Do get outside and walk outside, of course, masked and socially distanced. Try to get out of your house. It's really important and healthy to do so. For sure, complete or update your advance directives and discuss your wishes about aggressive medical interventions with your appointed agent, your family, and your primary care physician. And call us if you want to talk more about particular personal issues. So here's our phone number. It's 212-252-2015. Leave me a message with the best time for me to call you back, and I really will try to accommodate that particular information. For simple questions, you can always email me at judith@endoflifechoicesny.org. Thank you for your attention. I presume you've been paying attention. Who knows? I hope you have. I hope this has been helpful. And I look forward to answering any questions you might have. Thanks very much.
Thank you, Judy. So yes, now we have time to answer your questions. Judy, what if someone doesn't have anyone that could serve as a healthcare agent for them? What can they do?
It's a good question, and a lot of people ask about that, Lillian. The best thing to do is talk to your healthcare provider, your physician, or your nurse practitioner, and see if you're an appropriate candidate to complete a MOLST form, and medical orders for life-sustaining treatment. That's a document that you sit down and of course, you don't sit down necessarily right now, but you can certainly do over the phone or with telemedicine. and you discuss what your end of life goals are. This document was originally designed for people who have a bunch of chronic illnesses that are not getting better, and they're back and forth to the hospital a lot, and maybe they've reached the point where they don't want to go to the hospital, and they don't want to have aggressive interventions, and they don't want to be resuscitated. So this is an opportunity to document all of that stuff in one particular form that then becomes a medical order once the doctor signs that form. And the presumption is, and I think it's the case, particularly in upstate where I understand these are used much more frequently than they are perhaps in downstate where I am, they become medical orders and they're part of your permanent record. And the idea is that they will be paid attention to. So that's one thing. The other thing to do is you can write down what your wishes are. And the goal, of course, the tricky thing here is you need to have these things witnessed. It's amazing how many people actually can do that. You think that it's really, really hard to do, but it actually isn't. You know, the postman can witness your signature, you know, if you ask him ahead of time. And write down what your wishes are. There are forms that you can download from the internet for New York State's Living Will, or you can just write what you want on a piece of paper and sign it and date it and have somebody co-sign your witness your signature. I know that there's information about how you can get witnesses from afar, but it's pretty complicated. If you have particular questions about that, send me an email and I'll get that information to you. But so the first option would be to try and complete a MOLST with your primary care physician or your nurse practitioner. And the second would be to just write your own directive, what you want, what's important to you, what your goals are, and what kind of care you want, and get somebody to witness that and sign it yourself, and you'll be good to go. Make copies.
So in your talk, you mentioned a trial period for ventilation or other interventions. Can you clarify what that might mean, what that looks like, and in thinking in terms of potentially survival? So I guess the question is, one, just clarifying what that means, what someone may want to specify if they want a trial period, and also whether there are other things you may consider as circumstances, such as likelihood of survival rather than a defined time point.
Well, so here's the challenge with COVID, right? Because I have certainly seen stories that indicate what happens is if ventilation is required, if mechanical ventilation is required, you're often in an intensive care unit. There's a lot of monitoring that's going on about the amount of oxygen in your blood and what the exchange of oxygen is and how well you're doing, and whether they're able to lessen the amount of oxygen they're having to give you in order to get a sufficient amount of oxygen into your blood. And there comes a time often when the physicians who have regular meetings, the staff will say, geez, this guy's not getting any better, this woman's not getting any better. She's been or he's been on a ventilator for several weeks now and not improving. Is this time to switch from aggressive treatment to comfort care? Now, they're not going to make that decision without talking to the family. So they're going to have a discussion with family members. And that's where the family who has ideally had a prior discussion with their loved one will say, you know, we talked about just this thing, and Grandpa said that he did not want to have to die on a ventilator. And if it looks like he's not going to be able to get off of that ventilator, after a couple of weeks, he wants it stopped. Or they're going to say, no, you know, he's always said he wanted to live to be 105 and he's only 80 at this point. We want to do everything we can to help him manage to give him every chance he can. So it's an ongoing dialogue, and it's very hard, Lillian, for me to say what a regular period of time is. In the past, I could say, yeah, you have a 2-week trial, and then you have a family meeting and everybody comes back together again. And we talk about, is this working? Is it not working? It's not so easy to tell anymore. You guys have all read stories about people who've been on ventilators for a really long time. They've been in the ICU for months sometime, and they are able to be successfully extubated in time. Now, for sure, we're also learning that people sometimes have really, really, really difficult to manage long-term symptoms. But that's the reality of this damn disease. We don't know enough yet to be able to predict who's going to come off of the ventilator, who's going to have long-term problems, and who's not. Everybody gets to decide what their values are, what's important to them, but their job is, their responsibility is to communicate those values and those wishes to their loved ones, who can then advocate for them over the phone, over the iPad, with the healthcare team in an emergency in the ICU. That's the best I can do. It's a tough question. It's a tough situation.
So you've mentioned comfort care. Can you talk a little bit about what comfort care is and whether someone can be getting comfort care while they're also getting life-sustaining interventions?
They ought to be, for sure. And comfort care is focused on the quality of life and symptom management with the goal of keeping that person as comfortable as possible with the least amount of interventions that are keeping them basically tied to the bed. But in answer to that second question, it's very important that palliative care be a part of what's going on in the ICU or the emergency room. And increasingly, palliative care consults are being called on people who have many, many symptoms that have to be aggressively treated. And the job of palliative care is to focus on quality of life issues and symptom management at the same time as life-prolonging interventions are being provided. So lots of oxygen, aggressive interventions to keep the lungs expanded and without glop in them, but at the same time with morphine and anti-anxiety medication and muscle relaxants and things to try and keep that person comfortable. Music being played that their family knows that they would like, being able to hear their family members. These are all part of symptom management, comfort care that can easily then transition into hospice care if a decision is made that, you know what, we have to pull back, we want to pull back on these aggressive interventions and focus exclusively on comfort care, which would be opiates for pain, anti-anxiety medication, and trying to get them out of the ICU and perhaps back home on comfort care. But I'm glad that you asked that, because palliative care, which focuses on symptom management and quality of life issues, should be a part of the care that's offered to these people from the very beginning.
So how might COVID impact the end-of-life options or choices for people that already have progressive or terminal conditions such as cancer or heart disease?
It's hard for me to answer that because it depends. It just depends. I mean, people who are at heightened risk, people who have underlying diseases, most likely are at greater risk of dying of COVID. It's hard to keep getting the treatments that you were getting before. Therefore, chemo gets interrupted, radiation that's given for treatment rather than for symptom management gets interrupted. And people that have underlying conditions, they don't have the ability to fight off all of these multiple assaults on their bodies. But you know what? The problem is, Lillian, again, at this point, even though it's 6 months in, we really don't know enough to be able to predict who's going to come through all of this and who isn't. So again, it's up to the individual person's personal values about how much and for how long they want aggressive treatment and how long they want to keep trying life-prolonging interventions for things that they might normally have been able to do one thing at a time. But if it's all added on top, it's very hard for some people to be able to cope.
So any suggestions as we transition into fall flu season in order to be prepared for a potential spike in COVID-19?
Besides, everybody must get a flu shot. Must. And you must encourage everybody. You have to get, you kind of have to get in your family's face, right? Don't we all have family members who say, I've never had a flu shot. I don't need a flu shot. Why would I need a flu shot? I've never had it. This is the year. This is the year. Because it's not just for you, you're putting other people at risk as well. And the damn problem is, COVID is COVID, right? This one happens to be COVID-19, blah, blah, blah. But there are other COVID infections that are, quote, whatever the hell that means anymore, regular flu, right? Seasonal flu. And so it's very hard to distinguish the symptoms of one, at least initially, from the symptoms of another. So you're doing yourself and everybody around you a favor by at least taking care of those viruses as best we can. And of course, the seasonal flu virus isn't 100% effective, but it's something we know we can do that does help. So let's do it. And this is the year to do it. Although I would say on the good side, the fact that we're not flying everywhere, we're not going down south, part of the huge flu season is people going down south and then coming back up again and being on planes and being in close environments with in crowds. So the thinking is, we don't know yet, we'll find out, that there might be less flu this year, seasonal flu, but I'm not suggesting that's any reason not to get a flu shot. But they're suggesting that perhaps it's not going to be quite as horrific as we fear, but who knows? Who knows?
So what do you do if you don't want any intervention? So you want to stay home, but you're having trouble breathing or you're having other severe symptoms. How can you is there any care that you can still receive, and how would you access that care from home?
You need to be in touch with your primary care physician. You need to be making decisions with as much professional advice as you can get. And listen, people can stay at home even if they choose. I mean, what we want here is informed decision making, right? We don't want decisions made out of an irrational fear that has no basis in reality. But people can make a decision that they're prepared to die sooner if that's what's required here, in order to stay at home with their loved ones. But they don't want to die gasping and miserable. Who would want to do that? So, by gosh, hospice is the solution here. Small doses of morphine is the treatment of choice for shortness of breath. And it can absolutely relieve that cycle of, oh my God, I can't breathe, oh my God, and then you get more anxious when you can't breathe. It breaks that cycle, and it absolutely helps. And hospice can and should be called sooner rather than later. Again, they're not being able to come into your house physically as frequently as they did in the past, although they still do that. But boy, they're getting really good at doing assessments by telemedicine and online. So for sure, call your primary care physician, tell them you want a referral for assessment for hospice. And the sooner you get those meds in the house and on board, the better. Absolutely.
And does palliative care or hospice that's home-based also have support for families?
Hospice does. The problem with, yes, hospice is a wonderful thing. And it's a team of, well, it used to be. It's hard to know anymore. It's so hard to predict. It's a team of specialists. So there's a registered nurse who's assigned to you. There's a physician that oversees the team. There's a social worker who provides both individual support to patients and to the family. And they are wonderful because this is what they do. They're very skilled. They can help with billing. They understand. Can you imagine understanding Medicare and Medicaid? And there's also part of the team are spiritual advisors, and they're wonderfully supportive. And so that team is available not just to the patient, but also to the family. As you know, with hospice, the center of care is not just the patient, but it's the family. That's the unit of care. The challenge with palliative care, which provides the same sort of things, and you don't have to be terminally ill to receive palliative care, and you can be getting palliative care while, as somebody asked earlier, while you're getting aggressive life-prolonging interventions. The challenge is that you have to go to the bloody hospital to get palliative care. It is, for the most part, not provided in the home because of insurance and reimbursement issues. Now, you should check with your primary care physician. It might be different in upstate, or some hospices are beginning to provide palliative care in the home, and that would be great if they are. I don't know whether, it's actually an interesting question that I'm just raising. I don't know whether COVID in and of itself is a, quote, terminal diagnosis. I don't know. But again, that's a question to put to your primary care physician. But if you're experiencing acute symptoms of shortness of breath, that is a medical emergency that somebody needs to be on that right now. So you need to be in ongoing communication with your primary care physician.
So if someone doesn't have a primary care physician, any recommendations for how they might go about finding one?
Go on, if you have access to a computer, go online and Google available doctors in my area, and then list your location. If there's a hospital, access the hospital's website and find out if they have a physician referral system. This is another one of those wake-up call things, right? In addition to completing an advance directive and updating your advance directive, it's, oh my goodness, maybe I need to be on this. It's very difficult for many people who have felt that they've been very successful, thank you very much, without having to go to a doctor, and they haven't gone to a doctor for years. And I know there are a lot of people like that in upstate New York. However, this kind of horrible medical crisis lets you know that there's a time when maybe you need to have a phone number, and you need to have, better than that even, is a relationship with somebody that you trust. You don't have to see them all the time, but they need to know who the hell you are, so that when you call and you say, I got a problem, I know I haven't seen you in a year, but it's a challenge. So I'm sort of babbling here because I'm trying to think out loud as I'm speaking. So get in touch with your local hospital, your community hospital, or the university medical center. Go online and put in your location and ask for a physician referral. And what you want is a general internist for the most part, or a GP or a nurse practitioner. Don't overlook nurse practitioners. They are wonderful, and they can provide a great deal of both clinical and emotional support to patients.
Someone asked if the slides will be made available. So we are recording this, and a link to the recording will be sent out to everyone who registered. It'll be available both on the End of Life Choices New York website and also the Death with Dignity Albany website. So our next question is about the MOLST form that you were talking about.
Yeah.
How far in advance can you complete a MOLST, or medical orders for life-sustaining treatment? Can you complete it when you're not ill?
Oh, sure. Oh, yes, for sure. The only reservation I have about a MOLST is it came about when people in nursing homes kept getting sent to the emergency room long after they'd lost the ability to advocate for themselves or even knew their name or had any family that could advocate for them. So they'd show up in the emergency room. There was no advance directive, and they would do everything because usually they got sent to the emergency room because they had a bloody fever, and long-term care facilities don't deal with fevers all that well. So they do all of these interventions, and then they would, and always there's something that can be done. And then they'd turf them back to the nursing home, and then the cycle would repeat. And again, nobody would know what the hell they wanted or who to call. So some smart person, Pat Bomba probably, developed this mole in upstate New York and said, this is crazy. We've got to break this link. And so they developed this mulch, and it is originally, and maybe still is, printed on bright, hot pink paper, and sort of heavy paper at that, so that even busy ER people would find it when the patient's chart was transferred from the nursing home with them. And it would say, does this person have family? Who do I call? Do they want to be resuscitated? Have they had this discussion before with somebody? So to get back to your question, so it was designed for elderly people who had, in somebody's idea, maybe a couple of years left towards the end of their lives. But increasingly, there are people that say, you know what, I don't have anybody that I can appoint as my healthcare agent, but I understand that I need to somewhere get my wishes documented. And I do have a physician. I don't like him a whole lot, but I go see him every now and then. Take advantage of this time. Complete this thing, even if you're just in your 60s. Make a decision about whether you want to be resuscitated, but be sensible about it. I mean, I've had conversations with people who are in their 60s or 50s, and they say, I never want to be resuscitated. I say, wait a second. What if you're allergic to bees and you have a bee sting? You don't want to be resuscitated? And then, you get this shot of adrenaline and you're perfectly fine. What people fear is not getting back to the pre-insult stage, right? They fear that if they ever agree to be resuscitated, they will forevermore be dependent upon mechanical things. And that's what people don't want, and I get that. You can be very clear in stipulating that you don't want to have chronic dependency on anything, any kind of medical interventions. And you do want, and you should always say you want, aggressive symptom management. And even if that pain management secondarily hastens your death, that's fine with you. That's what you want. All of that can be put in a MOLST, and it's very important that you do it. So I would encourage people who are absolutely sure that there's nobody in their life that they can ask to be their healthcare agent, that this is better than nothing, and I would absolutely encourage them to complete one.
So you were talking about flu shots earlier. Would you also recommend that someone who is currently receiving palliative care get a flu shot?
Sure, why not? Not going to cause you any harm. But again, you've got a palliative care team, ask them, don't ask me. These are questions, these are sensible questions. You shouldn't be embarrassed about asking them of any member of your healthcare team. And I can't imagine why anybody would say, no, I don't think you should have a flu shot. You should have a flu shot.
So if someone has a loved one that ends up in the hospital with COVID-19, what are some things that they can do, not being able to visit, to still advocate for their loved one while they're there?
Yeah. So the first thing you want to do is find out how you communicate with their caregivers. And the caregivers are very sensitive to this. They know how absolutely devastating this is for family members to be away from their loved one. So those nurses, I'm telling you, those nurses in the ICU, and you do know I'm a little biased in favor of nurses, in the ICU and the emergency room are going to start calling whoever is on that piece of paper that you brought in with you. And they might, if you haven't had a chance to put all of that stuff down, or you've got somebody in the hospital now, find out how you get a hold of their team. And usually what happens is there's a regular check-in each day with the family members. And so in anticipation of that call check-in, have your list of questions written down that you want to know the answers to, and find out from the care team whether you can have opportunities to speak to your loved one, even if they're intubated. They can put the phone up to their ear, and you can talk to them, and you can tell them the things that you know they would want to hear. You can play the music that you know that they would love. And I'm telling you, there are wonderful stories of people who have been discharged and who have said that contact with their loved ones through the phone held up to their ear was so important to them. And you know, you can do that FaceTime. And even though, you know, it may be kind of scary initially to see your loved one with tubes in them, nonetheless, they can see you, you can see them, and you can speak to them perhaps more easily than their caregivers if they speak a language that all caregivers don't speak readily. And it's very important to keep doing that. So make a list of the questions you want to ask each day, and then communicate that stuff to the rest of the family, not just you, but let everybody else know what's going on. And try to find times that you can call when it's sort of a little bit slower in the unit, so that nurses will be available to help you with this. Find out from them the best time to call and how many calls you can make each day, and keep doing it, keep doing it. You have to advocate for what they would want.
So if a person has no insurance and or is undocumented, where can that person go if they're feeling sick with COVID symptoms?
They still go to the emergency room. Nobody can be refused care in an emergency room it doesn't matter whether you're documented or not. You absolutely go and you get that treatment. You get that assessment and you get that treatment. Nobody's going to ask, and nobody's going to throw you out, because it's required. You have to get treatment when you show up in an emergency room and you need emergency care.
So you mentioned that one of the effects of COVID is delayed care for existing conditions. But what about preventative care? How might someone weigh the risks of, you know, potential exposure in getting preventative care like an annual physical versus the benefits of having that screening done?
Right. Again, these are questions that you should be talking to your primary care physician about. And a lot of that sort of routine screening care, they've now figured out how to provide it safely. I mean, many people are doing it over telemedicine. I mean, the thing that can't be done, obviously, over telemedicine is blood draws and other kind of you know, x-rays and stuff like that. But preventative, so I think that initially there was a great deal of fear of even, you know, being on the same block as a hospital. That's no longer realistic. I mean, if your physician happens to have an office in a hospital, which some do, university hospitals, those docs do, you find out what practices they're using. How are they keeping their patients safe? You need to find out what they're doing to keep you safe before you decide that you're going to physically go and show up. On the other hand, if you need ongoing treatment for a life-threatening illness, you should be getting that treatment, and you should find out from your treating physician how you can best do that and what kinds of risks you're assuming. It's all about making informed choices again. These are complicated questions, and this is a complicated time, but the person to turn to is your primary care physician, or the people that know you best, who have been caring for you over time.
So there are many different kinds of masks, cloth masks, surgical masks, and then people have been hearing about N95. Which one is best, and how do you know whether the mask is right for you? Any given type?
I do not feel qualified to answer that. I am somebody who is not a very good role model in that I don't have an N95, but for sure, there are lots of different masks out there, and there's a lot of information out there about which masks are effective. The goal here is to keep both the droplet infection from going from you to other people, and to keep the droplet and the tiny, they're now seeing in the air from being transmitted. I think what's important here is that you have a mask, that you change it regularly. If it's wet, it's going to transmit things through it more readily and more easily. So you need to have a bunch of them. They need to be, here I said I don't know anything about this and I shouldn't be offering you advice, but I know that they should be at least 2 layers, and they should fit fairly snugly around your face. But again, there's a lot of information about that online if you want to wade through it. I mean, the goal here is to be respectful of those around you. If you cannot socially distance from them outside, and to keep yourself and others safe. I mean, that's what we're trying to do is cut the transmission. We've done great work here in New York. Let's keep it up.
So 2 other things I just want to add to the mask question. Thank you, Judy, is also to please make sure it covers your nose and mouth. If it's only covering your mouth, you're not protecting yourself or anyone else. And also some masks will have what's called an exhalation valve on the side. And yes, that keeps your face cooler, but that means that what you're exhaling is going out of the mask. And so that also doesn't offer protection to others. So it's something to be mindful about. And yes, there's plenty of good information online there. Can we get COVID-19 from surfaces?
I am not sure that I know the answer to that, but I am certainly not seeing that written about in the way that initially everybody was, bleaching their carton of milk when it came from the store. I don't think there is any significant documentation of transmission that way. But again, I'm not an expert in this. And let me say something else. It's occurred to me that individuals have variable comfort levels with assuming risk, right? So that's just the reality. That's part of who you are. If you are risk averse, maybe you're going to be really, buying those things and, cleaning off your counters all the time. And other people are going to be like, oh, for heaven's sakes. So you have to be honest about what your comfort level is. And you know what? You don't have to explain it or defend it. That's who you are, and that's what matters to you. If it keeps you feeling more comfortable and more in control, then that's what you should do. The challenge is you can't necessarily impose those requirements on other people who don't see the world quite the same way, aside from our agreed upon social distancing, masking, washing hands after you've touched things from outside. And what else, Lillian? What else? Don't be
social distancing. Yeah.
Yeah. But I think you have to recognize that people feel about this differently. I have a friend who, when we have dinner together, socially distanced, she practically doesn't take her mask off to eat. I mean, she kind of gets the spoon under there. I mean, and I've practiced not rolling my eyes at her because, this is how she feels comfortable, and we want to be able to be together. So that's what we do.
So I think adding to the mask question, someone is asking, what about face shields, either instead of a mask or with a mask? Any thoughts?
The little bit that I've read about that is, although face shields may appear appealing because they're not quite so tightly affixed to your face, they are by themselves much less effective in preventing transmission. A face mask shield with a mask is considered admirable and very effective. But as I understand it, and you may know more, Lillian, than I, without that mask underneath, they're not considered effective.
That seems to be the case, but I think there's, just like you were saying, there's still a lot of studying and
Yeah.
uncertainty, and certainly, you know, the length and the width of the mask, the face shield also plays a role.
Right, right.
And so we got a question regarding personal pulse oximeters, so measuring, which measures the level of oxygen in the blood. So is it worth it to have one of those to determine if you may have COVID-19 or if the infection is serious before some of the symptoms appear that you talked about?
Well, I think people that have any kind of chronic lung problems, lung issues, like, as I said, COPD, emphysema, asthma, where they can become acutely symptomatic, I think it would be wise to have one of those in the house. I'm not sure that I was going to say, I'm not, well, so I guess I should pause and say this is not my area of expertise by any means. An acute, I mean, one of the things that they've learned is that people can be admitted to an emergency room. They've been doing okay. You know, they were getting shortness of breath. They were having some problems. And then all of a sudden they become really acutely short of breath and they go to the emergency room. And the healthcare team is astonished at how low their oxygen saturation level is. Now, would it have been better for them to be walking around with one of these pulse oximeters on their finger for weeks ahead of time, and particularly if they didn't have any great symptoms? I don't think so. But if you are experiencing symptoms of shortness of breath, call your physician, call your primary care physician or your nurse and say, here's what's going on. Should I get one of those things? And at what level do I call you and get myself into the hospital? Because I don't actually know that number, but I'm sure somebody does, and I'm sure there's a number. I don't know that it's in and of itself diagnostic. You know, they used to say, you know, I still, you know, they go around taking everybody's temperature, supposedly people and it's up to the building management down here in New York City as to what the rules are for the building. I think they still are, you know, taking a temperature of everybody that walks in the building. I don't think that that is considered diagnostic anymore. I think there are much more effective ways of diagnosing this disease than, for example, a fever. Because, you know, there are a lot of people, as we know, who are symptom-free and are positive and are indeed capable of infecting lots of people if they're not wearing a mask and keeping socially distanced. So I think that if you have a history or you have been experiencing chronic respiratory issues, then that's a good investment, but talk to your primary care physician and get advice from that person.
So do you have any advice how to respectfully ask people to social distance who may get defensive or not want to follow the guidelines?
Oh my God. Well, obviously you don't want to get into a fist fight.
That wouldn't socially distance you.
So, I mean, it's hard, right? It's hard. Different people have different ways of responding to when they feel they are at risk or put at risk by somebody else's behavior. And it's not just around COVID, it's around lots of other things. You know, we live together in close proximity oftentimes. I mean, I have dogs and there are people that are terrified of dogs. My job is to be respectful of their fear, right? So the people that, for example, refuse to wear a mask or refuse to socially distance, I would probably recommend that you remove yourself rather than trying to get them to respect what ought to be common sense rules. And I think that, you know, the poor people that work in stores are being asked to do this. This is now their job, right? They have to keep people socially distanced and they have to keep people masked. I read somewhere, I thought it was really interesting, that one of the most effective ways, they were comparing what people do in China and what happens here. Peer pressure is very effective, right? So even if you're not specifically saying to somebody, get out of my face, there's a lot of nonverbal communication that can be pretty effective. And I do think that the more people that follow these common sense rules, they will in turn encourage more people to do so, because peer pressure is really pretty important. And frankly, we all want the best for ourselves and our loved ones. You know, clearly there are going to be dopes everywhere that don't believe in the germ theory of disease, or they don't believe in COVID, or who the hell knows what. We can't change them, but we can certainly stay out of their space so that they don't infect us.
So statistically speaking, is COVID considered a leading cause of death to the population? How does it compare to other diseases such as heart disease or cancer?
It's getting up there. It's getting up there. It's, I think I read somewhere, and again, this is not my long suit. Could it be the third leading cause of death right now? I don't know.
I'm not sure.
So the answer to that is I don't know. But my God, you know, I mean, something like we have 4% of the world's population and 20% of the COVID cases. So we're not doing much of a job here in preventing infections. I think across the country as a whole, hospitalizations and deaths are coming down. And I think in part that's because even though the positivity rate is going up with all of these kids in school and, you know, they want to party hardy, and the schools haven't yet figured out that they not only have to kick the kid out, but they also have to keep their tuition that their parents paid, and they don't get it back if they're, I mean, I've heard that they're now doing that in colleges. But those young people who become positive, they don't die. Or they don't die at the rates that elderly people do, or their grandparents or their parents for that matter. And so the problem is that the plateau is flattening, but it's not coming down in terms of the infection rate. And there's always a lag, I don't need to tell you, of a couple of weeks after Labor Day, right? Labor Day. So we're expecting we're going to have a spike in another couple of weeks. So, and apparently there's huge numbers in the Midwest after, I believe it was South Dakota that decided that they should, you know, have 500,000 motorcyclists meet together in Sturgis, South Dakota. So that's gone out all across the country. I mean, hundreds and hundreds and hundreds of infected people now as a result of that. So I'm getting carried away here, sorry.
Okay, it's all very helpful. So you mentioned contact tracing earlier. What is it and why does it matter?
Contact tracing is, I gather, one of the most effective ways of breaking the chain of transmission. And what it is somebody who has developed COVID, is positive for COVID, is contacted by somebody, usually by phone, but if they don't have a phone, they go in person, I think. Don't hold me to that one. But they want to know who they have been in contact with since, I believe, since they became infected. Is that right, Lillian? It's since they were positive?
So I think that when someone has come up positive, they're trying to trace back where the point of infection was.
Yeah.
So they may ask questions about symptom onset if there was a delay, because they're trying to get a timeline.
Right. But the problem is that the people that do that kind of testing and follow-up have to be appropriately trained. And I don't think, at least not in New York City, that training is not happening, because there are people that are very good at that. They through the HIV/AIDS crisis, the contact tracers were very well trained, and they were able to do that effectively to find out who might also need to be tested. And that's the goal here. Let's test those other people and then find out who they were in touch with and test those people, so that you're breaking the I had no idea I was infected. I had no idea that when I went to the grocery store or saw my family or was in my pod where I thought I was safe because I've been safe. Why would I not be safe? Well, so it's terribly important. And I don't think that in some states, I believe they have been much more effective, like Massachusetts, for reasons, I don't know why, but they have. And that's not been on the front burner in New York State, I think perhaps because we had so many cases, it was impossible. Well, now that the rate has come down, it ought to be happening again. But again, in New York City, we have not done a good job. Maybe you guys are doing a better job in upstate. You'll tell me, I don't know.
So the next question is about something I think a lot of people are talking about, and that's antibody testing. Mm-hmm. So are the antibody tests accurate right now, and do you recommend that everyone get one?
I think the accuracy is improving. I think there are still false positives and false negatives. I think what we all want to see is the rapid testing, right? The rapid testing, whether it's like a pregnancy test that you can do at home, whether it's your own swabbing your nose, the front of your nose, not the back of your brain, and getting results within the hour or within several hours. Because the problem with the antibody testing that takes days, it's too late. When you find out you're positive, 3 or 4 days after you were tested, who knows who you have exposed to the virus that you didn't even know you had. So I think that they're getting better at knowing which tests work. I mean, the CDC and the NIH went through some terrible times where they didn't do enough testing. They were too restrictive in who could do the tests, and then they decided to open it up to everybody. So they had all of these non-validated tests but that was then. Now, I think they're doing a much better job of being sure that their tests are good and that people know how to provide them. But truly, what we need to get to, and they're working on that and they're making progress, is the rapid fire tests that test for titers of antibodies, because they're also knowing that some people have really low titers of antibodies, and are they infectious? Were they ever in? I mean, they don't. So this is evolving. I think that was my first slide. This is evolving, this information, and I truly do not consider myself an expert, and I'm trying not to give you inaccurate information. I should just say, I don't know the answer to that question.
So rewinding a bit, going back to advanced directives, I know you mentioned the healthcare proxy form to designate someone you trust to make medical decisions for you if you're unable, and also the MOLST form, medical orders for life-sustaining treatment. What about living wills? Where do they fit into this?
They're better than nothing. Again, they're better than nothing. Even though they are not recognized by legislative mandate in New York State, you have every right to sit down with a piece of paper, a big yellow pad, and say, here's who you are, what day it is, what time it is. Here are your wishes about interventions at the end of life, what you would want, what you don't want, or as you're nearing the end of life. Here's what you are concerned about. Here are your values. The more information you can put down there, the better it is for somebody to come to know who you are, even if you can't speak for yourself. But you need to say very specifically what you want in terms of interventions. Do you want all kinds of aggressive interventions, so long as there is a likely chance that they will be effective? If they're not effective, do you want them withdrawn at a certain point and be kept comfortable so that you don't have to endure chronic reliance on medical interventions? You can put that down. and then get it witnessed, sign it, get it witnessed, date it, and share it with your healthcare professional. Send a copy. You can print it out, copy it, go to Staples, I think they're open, and get it copied and send a copy to your primary care physician, and then call that person and say, listen, I sent you that living will. Is this okay? Do you understand? Here are my wishes. Have I put everything in there that you need to know in order to be able to provide interventions for me if I become acutely, life-threateningly ill? So don't just complete it and then put it in some pocket someplace. You need to share it with your physician. If you have any family members who they might call, be sure that they have a copy of it. I mean, I know lots of people that don't want their family involved at all. Even though they have family, they don't want them making decisions. So you have every right to say what you want, put it down, date it, time it, get it witnessed, and send a copy to your primary care physician, but then follow up with a phone call and say, okay, I sent you this thing. Can we spend 15 minutes for you and I to talk about what I've written here?
So, if someone does not have a healthcare agent that they've appointed and they end up, let's say in the hospital, unable to make medical decisions for themselves, what happens?
The default position in any kind of an emergency room is to treat first and ask questions later. So they will do everything they can to treat your disease with the goal of getting you well. I mean, that's what doctors do. And certainly that's the goal of an emergency room. They're going to stabilize you. They're going to, if there's time, they'll see if there's any kind of advanced directive anywhere. Somebody will go through your purse or your wallet to see if there's anybody that they can call or who they should be in touch with. And they will do that so long as they think that those interventions are being helpful. If it seems that after days and weeks and sometimes even months that it's not, that they're not winning this battle, then not just by themselves, they have to get permission from other people. I'm thinking about, we have something called the Family Healthcare Decisions Act. If you haven't completed any kind of an advance directive, they will go to people on this sort of arbitrary list. So it would be your spouse, it would be your adult kids, it would be your adult siblings, and they go down the list until they finally reach somebody that they can say, what in the hell would she want? Or what in the hell would he want us to do here? And it gets much more complicated if you are dependent upon life-prolonging interventions. Before that can be withdrawn, they don't do that lightly or easily. They will have a committee that comes together. There'll be an ethics committee meeting. There will be, other people are much more knowledgeable about specifically what's in that law than I am, before they can withdraw those life-prolonging measures. The other thing that might happen is you get turfed to a nursing home. So, and there are not that many nursing homes that will accept patients on ventilators. So it gets much more complicated. But the default position when you end up in an emergency room is that they will treat you and they will try to stabilize you and they will then figure out where to transfer you.
So is it better to complete advanced directives with an attorney, or is it something that is fine to do yourself?
Well, I have a bit of a bias against attorney drafted advanced directives just because they end up being so long and so complicated that I can tell you for sure nobody's going to read through them, particularly not in an emergency. So the best, as I've said over and over, the best is to have a person who knows your values and wishes, that treating team can call. So you want a healthcare agent. If you have a physician who's, an elder law attorney, for example, who's experienced in completing advanced directives, they understand the importance of keeping it simple. And that's what I would recommend, is that you keep it simple. You can go to your attorney, but keep it simple. Don't get a lot of whereas and in the party of the first case and in so much as and furthermore. I mean, keep it simple. Who's your agent? What are your wishes? Do you have particular instructions around things like feeding tubes or conditions that would be unacceptable for you to have to be in and have to endure indefinitely?
Well, thank you so much, Judy. This was so informative and helpful, and unfortunately, that's all the time that we have. So if you did not get a chance to have your question answered, or if you think of a question later, or maybe have a more complex or personal question, please feel free to reach out to Dr. Schwarz at 212-252-2015. That's the number on the screen. And for simple questions, also feel free to shoot an email to Judy at judith@endoflifechoicesny.org. We also encourage you to visit the End of Life Choices New York website at endoflifechoicesny.org. Again, endoflifechoicesny.org, to learn more about our services. So Judy, before I turn it over to Bonnie, any final thoughts or information you want to share?
I tell people to try to find some humor in all of this, which is not so easy, but to keep smiling as best you can and reach out to help those that need help now. Just try to, let's all get through this together, which is what we'll do. Thank you for listening. This has been a lot. And thank you for your very challenging
wonderful questions.
Oh
yes.
Yes.
Thank you. Thank you. Thank you to our viewers, and thank you for all of those questions. And thank you, Judy. And Bonnie, I turn it over to you to wrap up.
Thank you, Lillian. And thank you, Judy, for being such a wealth of information and a source of really down-to-earth practical hints and tips and explanations that are really hard to come by sometimes. Thank you, Lillian, again, for managing all the technical aspects of the webinar, and to End of Life Choices New York for co-sponsoring the program with us. We do miss seeing you in person. But
me too.
Yeah.
We're all getting used to this new way of life, and this technology might have enabled some of you who can't attend a program in person when they resume someday to do so from the comfort of your home. So there's an upside too. We do hope to have a follow-up session to this webinar at some point in the future, but please do note that the previously scheduled program on September 23rd has been canceled. And just watch your emails from us and you'll find out about the next program. In case you are wondering about the status of our legislative campaign, I invite you to check out both of our websites, deathwithdignityalbany.org or endoflifechoicesny.org for lots of background information and useful updates. And thank you all for wonderful questions. Thank you again, Judy. Stay well and stay safe, everybody. Have a good afternoon.
Thank you so much. Take care, everyone.
Bye-bye.